Okay, good afternoon. I'm Dr. Correia. This is Clinical Correlation 1. This is a pre-recording of a lecture I'm going to give Wednesday, August 12th at 1 to 3 p.m. And then we'll do this live on Wednesday. So this is just a practice on my part to make sure everything's in order. The topic of today's lecture is the control of acid-base balance, and we'll be discussing the respiratory and metabolic controls. Specifically, we'll be discussing the lung and the kidney regulation of pH. Now, I've already shown you these objectives. These are the objectives that I showed on L3, and these have to do with pH and Henderson-Hasselbalch. They have to do with the functional groups that are involved in regulating catalytic activity and the groups that are involved in transport of oxygen and CO2. And on the third page of that series of objectives, I mentioned that we would discuss pH balance and respiratory control, the lung function, and I mentioned we would discuss metabolic control, kidney function, excretion, reabsorption of bicarb, etc. And that lecture ended with this slide. There were a couple of problem slides afterwards, but it discussed the fact that we would recover this series of topics and discuss Henderson-Hasselbalch using bicarb as the conjugate acid, conjugate base pair. So it's not really carbonic acid in bicarb. You can see down here and up here it lists it as carbonic acid, because carbonic acid completely dissociates to bicarb. The equilibrium is actually between CO2 and bicarb. And so we actually use CO2 as the acid and bicarb as the base. And that's what we're going to discuss today. Okay, so here's that overall reaction. It's CO2 plus water. So CO2 is a gas. It goes into water and is immediately hydrated to make carbonic acid, which then loses a proton and makes bicarb. The reaction for the first equilibrium constant for the first step is, the equilibrium constant for the second step, the way this is written, K1 is over here. K1 is here in this nomenclature, I guess. Is a proton and a bicarb is the product, and carbonic acid is the reactant. And then the first equilibrium can be written down as carbonic acid is the product and CO2 and water is the reactants. So if we combine these equations by solving for carbonic acid in terms of K2 times CO2 and water, and then plugging that into the first reaction, this is what we get. We get K2 is equal to proton times bicarb divided by K2 CO2 and water. And then if we bring the bolded symbols here, K2 and water, to the left, then we can define a new equilibrium constant, K3, that is the CO2 solubilizing and releasing a proton to make bicarb and proton. So we'll reduce the two steps to the overall reaction. Okay, and when you do that, you can write down that equation as a conjugate acid-base pair. Here's a rewriting of that equilibrium constant. And then we can rearrange this the same way we rearrange the equation in L3, bring proton to the left, 8K3 to the right. Take the logarithm of the entire equation. The log of 1 over h is actually the log of h to the minus 1, which is actually minus the log of h, which is pH. And the same here, the log of 1 over K3 is actually pK3, because it's log of K3 to the minus 1. It's minus the log, it's pK3. And then this final term over here is still the log of the ratio of the conjugate base over the conjugate acid. So this is simply writing down Henderson-Hasselbalch for this overall equilibrium. Okay, this volatile gas in equilibrium with bicarb. And this turns out to be the major buffering system in the open system that is our lungs. Okay, so here's a slide that lists some of the important parameters pertaining to this reaction. Okay, so here the equilibriums may actually be switched here in terms of K1 and K2. I should probably change that up above. So the equilibrium constant for the first and the second reaction, and you can see that the rate constants are listed here for this at least first solubilization reaction, and then the dissociation to give a proton and bicarb. And then we're going to plug numbers in to this overall reaction, the 5.4 and the 3.1 instead of the -4. And we're going to correct for the water concentration. And you can see that this comes out to a number that when you take minus the log, you get something close to 6 at 37 degrees. Now, in practice, the pK that we use in physiological buffers is actually 6.1. Okay. Okay, so for this reaction in some kind of a test tube environment, this is what you get at 37 degrees. In practice, the pK for this overall reaction is actually around 6.1, and this is what we'll actually use today. So, for example, if you were to check the blood pH of a patient and we found that it was 7.1, and we found that the bicarb concentration was 8 millimolar, then the question is, so this is a pH problem using Henderson-Hasselbalch, what is the concentration of CO2 in the blood? And remember the pK where you're going to use is 6.1. So 7.1, the pH, is equal to 6.1 plus the log of 8 millimolar divided by CO2. So 7.1 minus 6.1 is 1. The anti-log of 1 is 10. And so 10 must equal 8 divided by CO2, plus then rearranging CO2 must be equal to 8 divided by 10. So the CO2 concentration must be 0.8 millimolar. Okay. So given the pH, know the pK, given one of these concentrations, you can solve for the other concentration. You have to take an anti-log and then rearrange the equation to do this. Okay. At normal blood pH, which is 7.4, the sum of the bicarb and the CO2 is 25.2 millimolar. What is the concentration of bicarb and CO2? Okay. So the pK again is 6.1. So 7.4 minus 6.1 is 1.3. The anti-log of 1.3 is 20. Okay, so just take the log of 20 and you will get 1.3. So 20 equals bicarb over CO2. Okay, and so that's shown in this first part. And bicarb plus CO2 is 2.5. So we have two equations, we have two unknowns. Okay, so if we rearrange this equation so that its bicarb is equal to 20 times CO2, and then we plug 20 CO2 into the second equation, so we have 20 CO2 for bicarb plus bicarb is equal to 25.1. So that means it's 21 CO2. And so we divide 25.2 by 21, and the answer we get is 1.2. All right, so normal CO2 is 1.2 millimolar. And then if we substitute that 1.2 into the sum equation, 1.2 plus bicarb equals 25.2, that means that the bicarb normal concentration is 24. All right, so normal pH is 7.4. Normal bicarb is 1.2. and normal CO2 is 1.2, and normal bicarb is 24. Okay, so you need to be familiar with that. You need to know those normal numbers. Okay, so here's a question, and what I can do here, and I'll do this during the actual lecture, is I'll click here and hit start a poll, and then I'll choose something that has an A, B, C, D choice, and you'll be able to make that choice. If the pH of what is the pH of a solution with 24 millimolar bicarb? This is normal, and 0.6 millimolar CO2. This is less than normal. Normal is 1.2. Okay. So there are a couple of things that you need to think about when you're solving problems like this. We're going to just plug this into Henderson-Hasselbalch. Okay. We don't know what the pH is. Okay, but it's going to be 6.1 plus the log, okay, of 24 divided by 0.6. All right. Now, the normal ratio over here was 20, and we lowered this by a factor of 2. So this now is going to go up to 40. Or it's going to be the log of 2 times 20. Okay, or it's going to be the log of 2 plus the log of 20. Okay. So the change here is we've lowered the CO2. That's lowering the acid concentration. Consequently, the pH must go up because we have less acid. The only answer above 7.4 is 7.7. So that's what the correct answer is going to be given the choices you have. The log of 40 is the log of 2 times 20. The log of 20 is 1.3. That's what gives you 6.1 plus 1.3 is 7.4. And then the log of 2. The log of 2 is 0.3. The log of 2 is 0.3. Okay, so 0.3 plus 7.4 is 7.7. So you can do this a couple of different ways. Inspection, it's more basic because the acid goes down. Calculating the log of 40 plus 6.1. Okay, that must be 1.6. And the log of 2 is the change that is made here. That's a 0.3. It goes up by 0.3, so it's 7.7. Okay, so I'm giving you a lot of possibilities here. You need to find your way of solving these problems. Now, that's the equation for just the bicarb, but it turns out that your buffer in your plasma, in your blood, there are lots and lots of different buffering capacities. You have phosphate buffer in there. You have proteins that have histidine in there. You have lots of things that can act as buffers. Okay? And consequently, all of them have the same pH because the solution has only one pH. They all have slightly different pKs, and therefore they all have different ratios, but everybody is linked by a common pH. And so basically what's going on in this system is everybody is contributing to the pH depending upon their pK and depending upon their ratio. So the pH actually sets the ratios of all of the different things that might contribute to the buffer. And the buffering is the bicarb CO2 system plus the phosphate system plus other factors. Now, in addition to this, we also have lots of electrolytes and non-electrolytes in plasma and in cell fluids. And so you can see here a summary of all the different cations and anions in plasma. And what you should notice is that your plasma is predominantly sodium with some potassium, and then there is some other stuff, calcium and magnesium. All right. And then your anions are mostly bicarb and chloride ion with a bunch of other stuff. Notice there's some phosphate. There's a lot of protein. Notice there's a lot of protein in your plasma. Okay. And then there's some other things. But predominantly we have sodium, potassium, bicarb, and chloride ion. All right. Now, in your cells, you predominantly have potassium, not sodium. And then a bunch of other stuff like sulfates. And then you mostly have some bicarb, some chloride, a lot of inorganic phosphates, okay? And then a lot of protein. You'll notice it's the protein level in your cells is about 3.5 times higher than it is in your serum. In your serum, this is saying milliequivalents, it's around 70 mg per mil. This is around 20 millimolar, but it's around 70 mg per mil of protein in your plasma. And so it's around, I don't know, that looks 3.5 times as much. So it's around 250 mg per mil protein in your cells, okay? So there's a lot of other stuff that's there that contributes and be taken care of. Now, I'm making the point that there are lots of things that buffer, but buffers are effective only if the pH is relatively close to their pK. So if a buffer is between plus and minus 1 of its pK, if the pH is between plus and minus 1 of the pK, that means that the ratio of the base over the acid is from 1/10 to 10 over 1. That's the plus 1 minus 1 in the log of the base over the acid. And so the other factor that contributes to buffering capacity, besides being close to the pH, is a high concentration also increases the buffering capacity. So in blood plasma, the phosphate, dibasic monobasic phosphate with a pK of 6.7 is actually less effective than the bicarb CO2 system with a pK of 6.1 due to the fact that the bicarb CO2 has a 20-fold higher concentration, okay? So the phosphate is only, if these are around 25 millimolar, then this is only around 1 to 2 millimolar, okay? And so they are not really concentrated in your blood, all right? In addition to that, at pH 7.4, we're on the basic side of the pK for bicarb. Then we mostly have the bicarb, and so our bodies produce a lot of acid, and the primary CO2 species is the bicarb, so there's lots of base around to neutralize that acid when it comes out of your tissues into the bloodstream. So two things contribute to the large capacity of CO2 and bicarb. One, it's got a high concentration, and two, it's poised at that side of the titration curve to actually neutralize all of the acid that we produce. Okay, so let's do a problem with normal conditions. All right, and normally in the PowerPoint, if you're looking at the PowerPoint is set up to have animation to feed this in. Okay, so normal values are 7.4, 24 millimolar bicarb, 1.2 millimolar CO2. Imagine a patient with metabolic acidosis as a pH of 7.03 and a CO2 concentration of 1.1 millimolar. So the question is, what is the patient's bicarb? Okay, so again, I'm giving you two, the pH and a concentration, and you want to solve for the bicarb. So if the pH is equal to 6.1 plus the log of bicarb over 1.1, take this difference, it's 0.93. The anti-log of 0.93 is 8.5. So 8.5 is equal to bicarb divided by 1.1. So 1.1 times 8.5 is 9.4, okay? So if this patient's pH went down, their bicarb went down dramatically from 24 to 9.4. Notice their CO2 only went from 1.2 to 1.1. The CO2 doesn't change very much. Okay, we're going to discuss that at great length. Why is this happening where there's this big change in the bicarb? Okay, then the second part of this question is, what fraction of the bicarb has been used to buffer the pH? And so normal is 24. So it's 24 minus 9.4. So 14.6 was used. 14.6 divided by 24 is 61% of the bicarb got used. All right. But notice, there's no conservation of the mass. And what I mean by that is the 24 plus 1.2, the normal values up here, do not equal 9.4 plus 1.1. 9.4 is where the bicarb went. 1.1 is where the CO2 went. These are not equal to one another. Where'd it go? Where'd the mass go? Okay. Now in class, I would usually go, can you actually hear that? I'm breathing. Where did it go? The CO2 was exhaled. The reason that this doesn't go down very much, the reason that this doesn't go up, is we actually are exhaling it. The CO2 is a volatile acid, and the way the pH is regulated by your lungs is that the CO2 is exhaled. Okay? Now, let's think about that in a slightly different problem. Imagine we had a closed system. A system with a pH, what is the pH it's asking? If you had 24 millimolar bicarb, 1.2 millimolar CO2, and now to that solution, we're going to add something that causes acidosis. We're going to add lactic acid. Okay, so we're going to add 15 millimolar lactic acid. Okay, so what's going to happen is the lactic acid with a pK of 3.86 is going to dissociate. When it dissociates, it's going to release a proton. That proton is going to bind to the bicarb and then back react to make CO2. All right? So we start out with 1.2, and to that we add 15. Okay? So the 15 comes from reacting 15 millimolar of proton, converting the bicarb to CO2. So now the pH is equal to the pK 6.1 plus the log of 9. Notice this is now 9 on the right, bicarb. And on the left, we've increased this to 6.2. Okay? So if you quickly go into your calculators or something else where you can do this, and you take 9 divided by 16.2, and then you take the logarithm of that, that's actually a minus 0.25. Minus 0.25. Okay, minus 0.25. 2526 actually. So the pH actually goes down to something like 5.84. Okay? So in a situation where there's no way of getting rid of the CO2, you can't exhale this through the lungs, the pH actually would go down dramatically. Okay? The pH would go down dramatically to less than the pK because we're now on the acid side of the pK here. So in this problem up above, I say that this person has metabolic acidosis. Something is in the plasma that is titrating the bicarb from 24, where'd my pen go? Here we go. 24 down to 9.4. But instead of making more CO2, the CO2 is exhaled. So we still have 1.1. So it goes down a little, but it doesn't go down much. So in a closed system, we would be very acidotic. In an open system, we actually regulate by getting rid of the volatile acid. Okay. Now let's look at this one more time. This summary of cations and anions, all of the electrolytes in plasma, all the electrolytes in cell fluid. Notice that there's a space around the circulatory system that we refer to as the interstitial fluids. This is a space around the cells that surround the bloodstream. And this is in equilibrium with the blood plasma. And so notice there's less protein. There's almost no protein in there. This whole section is gone. But it's still predominantly sodium, potassium, bicarbon, chloride. Okay? So these are in equilibrium with one another. And this is sort of a reservoir of anions and cations that maintain this volume in the bloodstream. Okay. So now that we've done what we've done here in introducing the bicarb system, now we want to get into this in a little more of a clinical way. And we want to introduce some terminology that you're going to be using with Dr. Bhagat on Monday. And what we want to do is we want to introduce ideas or concepts that are going to be required to understand what's happening in the bloodstream. So we have to think about oxygen saturation, and this has to do with the amount of oxygen bound to hemoglobin. The fractional concentration of inspired air, that has to do with where are you getting your air from? Where are you getting your oxygen from? Are you breathing in normal air? And what is the normal concentration of oxygen in the air? Depends on what elevation you're at. But generally speaking, how much oxygen is in air? Or are you breathing pure air because you're on some kind of a respirator? Like all these COVID patients who are in the hospital. They tend to be on a respirator, and they tend to be getting pure oxygen. Okay? Then we're going to talk about partial pressure of oxygen in the arterial blood, because this affects the saturation. So in other words, how much oxygen is in that arterial blood, and that binding of oxygen to the hemoglobin is what determines the partial saturation. We're going to talk about that in much more detail tomorrow when we talk about hemoglobin. Then we're going to talk about something called a P50, which is essentially a binding constant. At what concentration of oxygen do you get 50% binding or half saturation? Then pH of the plasma, BUN, blood urea nitrogen, azotemia. This is a term that has to do with excess nitrogen sources in the plasma. This usually refers to a condition where you have kidney failure. Anion gap. This has to do with the cations and the anions. Do the numbers add up? And if they don't add up, why? Okay. And then there's something called osmolar gap. I won't talk about that a lot. Dr. Bhagat will talk about that with you. It has to do with total concentration of stuff in your plasma, electrolyte and non-electrolyte. So again, notice going back here, there's some non-electrolytes in here. And so that is included in the osmolarity, okay? That has to do usually with foreign material that you have in your body, that where you've ingested something that isn't charged, but it contributes to the osmolarity of the buffer. We're then going to rederive Henderson-Hasselbalch in a clinical form. We're going to be able to talk about the saturation curve in terms of the function of hemoglobin and its relevance to human physiology. So we're really going to talk about this more tomorrow when we talk about hemoglobin. So this is anticipating where we're going to go. You need to understand that when you ingest oxygen into your lungs, and then it transfers over into your arterial blood, and then eventually to the capillaries around your tissues, that there's a constant decrease in concentration of the oxygen until it's eventually delivered to the tissues. We're going to talk about what normal values are. And so you're going to need to know what normal pH, oxygen, CO2, bicarb, and SAT is. So those are things that you will actually be talking about with Dr. Bhagat. And then we're going to describe in some detail basic mechanisms of how the pH is regulated by the lungs and the kidneys. And in doing this, we're then going to be able to do a differential. We're going to be able to determine if we have a patient with a respiratory or a metabolic problem, and do they have an acidosis or an alkalosis? Okay. And then we're going to be able to say the primary problem is respiratory or metabolic, acidosis or alkalosis, but then they have a secondary compensation that improves the situation by turning it back towards normal. Okay, and so we want to be able to do this, and I'm going to show you how you go about doing this. And so when you work with Dr. Bhagat on Monday, going through the problems he's going to give you, you'll be able to understand this. Okay. And so then we'll be able to talk about hypothetical data for a patient and interpret their blood gas data in terms of respiratory or metabolic acidosis or alkalosis. Okay, so let's begin by talking about pH balance in respiration, what the overall reaction is, who are the major players, molecular details, and how we use Henderson-Hasselbalch in terms of CO2 as a gas, millimeters of mercury. Okay, so here's one rendition. I'm going to show you a number of these of what's going on when you and I intake oxygen and exhale CO2. Okay, this is involved in pH balance as well as involved in delivery of oxygen to the tissues, as well as in being involved in getting rid of volatile acid through the CO2. Okay, so we breathe oxygen into our lungs, and that oxygen gets transported to the tissues. Our tissues produce CO2 as a waste product from metabolism, and that CO2 is transported in the plasma, partially as bicarb, partially as binding to the hemoglobin in your blood, your red blood cells. Okay, and then is exhaled at the lungs as CO2. Okay, so this entire process is also being regulated by the kidneys, because the bicarb that this CO2 is converted to can also be excreted or reabsorbed in the kidneys. And in the process of doing all of this, we can be excreting acids, buffers usually that are protonated, into your urine. Okay, so we're getting rid of volatile acids through the CO2. We're getting rid of organic acids through the function of the kidney. All right. Now, there's lots of details in here that you're just now being exposed to. The proton that comes along with the CO2 is a form that makes carbonic acid, but that proton essentially ends up going onto hemoglobin as a protonated form of hemoglobin. So some of the protons are carried by the hemoglobin, which eventually reverses and is exhaled by the CO2. The process involves enzymes that convert water and CO2 into carbonic acid, which immediately then dissociates to a bicarb, which can be excreted. Notice there's carbonic anhydrase present in the kidneys, in the erythrocytes, and in the lungs to make these reactions occur quickly. So the CO2 gets converted to carbonic acid, which immediately dissociates into bicarb. The proton gets picked up by hemoglobin. And then at the lungs, the reverse happens. The proton is released. It re-reacts with bicarb. It then dissociates into CO2. The reaction is facilitated by carbonic anhydrase, and the CO2 is exhaled. Okay. So this seems like a lot of stuff going on. We're going to go over this a couple of different times. Okay. Here's another rendition of this. Here are your lungs. Here are your tissues. And this is actually now from the point of view of the oxygen. So we breathe in oxygen. The oxygen binds to hemoglobin. Upon binding to hemoglobin, it causes a change in conformation of the hemoglobin that releases a proton. The proton reacts with bicarb, makes CO2 and water. The CO2 is exhaled. The oxygenated hemoglobin is then transported through your bloodstream to the tissues. Okay, and then at the low partial pressure, of the oxygen in the tissue, the capillaries, the oxygen is released. The oxygen is transported into the tissues by passive diffusion and is used, therefore, in oxidative phosphorylation for metabolism. The hemoglobin then picks up a proton. The proton comes from the fact that the CO2 from the back end of metabolism reacts to make carbonic acid. It makes bicarb, releases a proton. The proton gets transported by the hemoglobin back to the tissues, and we repeat the cycle all over again. So notice this has the bicarb over here, but this bicarb actually gets transported partially in the plasma, along with the proton on hemoglobin that gets transported in the erythrocytes. And then the bicarb and the proton then re-react and then dissociate to make CO2, which it gets exhaled. So oxygen in all the way to the tissues, CO2 onto in the buffer, and actually is partially transported on the hemoglobin and is exhaled out into the atmosphere through our lungs. So this coupling of oxygen transport and CO2 transport is a major mechanism for providing a substrate for oxidation, oxidative phosphorylation, but also a mechanism for getting rid of acid, metabolic acid in a volatile form. Okay. Now here's a slightly different rendition of that, okay? A slightly different rendition of that. What's going on exactly in the erythrocytes involves transport of ions across the boundary, all right? And so what I mean by that is the proton gets taken up, and when it comes into the erythrocytes, that proton has to exchange with another cation. So there's a release of potassium. So you'll talk about the transport of potassium out and sodium in. And this process is then reversed later on, okay, with the proton out and the potassium in at the lungs. But notice that what it's saying is that the acid that comes into the erythrocytes is partially neutralized by binding to hemoglobin, but is also partially neutralized by binding to proteins and to phosphate. Okay, so you can see that in the erythrocytes, there is also the buffering capacity of the proteins and the phosphate buffer. Now, the protein that we're talking about here in erythrocyte is actually hemoglobin. Okay, so there's lots of histidines on hemoglobin that can be involved in this buffering capacity. And notice, okay, these protonated forms then deprotonate and let that proton go so that it can recombine with bicarb, get turned into CO2. So this buffering capacity that we're talking about is not just the bicarb, and it's not just the hemoglobin, but it's a whole series of, not just the proton that's carried by the hemoglobin, but it's also a whole series of other protonatable sites that are involved in this process. And notice the process is reversible. At the tissue, proton net binding, and at the lungs, proton net release. Okay. Now, a slightly different rendition of this combines this with what's happening in the tissues and what's happening in the lungs again, but it also combines it with the role of an enzyme. So notice that carbonic anhydrase is involved in converting the reaction so that hemoglobin is partially protonated. So some of the protons are being carried by the hemoglobin itself. Some of the CO2 is being transported by the hemoglobin itself. Notice this CO2 moiety at the end terminus of the hemoglobin, okay? And then the carbonic anhydrase converts some of the CO2 into carbonic acid, which then dissociates. There's the proton that binds. There's the bicarb that gets transported in the tissue. Notice when the bicarb gets released, chloride comes in. So again, there's a charge balance here. And so there's a transporter that allows the bicarb out and a chloride ion in. So the net charge in the erythrocyte is neutral, or there's a neutral change. Back at the lungs, everything reverses. The bicarb comes in, the chloride goes out. There's a reaction with a proton released from the hemoglobin to make carbonic acid. The carbonic anhydrase converts this to CO2, and water, the CO2 comes out and we exhale it in the lungs. So a series of steps partially catalyzed with an enzyme, partially involving anion transporters, reverses itself near the tissues, and then again reverses itself at the lungs. Okay, so the net overall reaction looks like this from the perspective of hemoglobin. All right, there's a hemoglobin molecule that can bind oxygen, but it also has a number of other effectors that I'm going to tell you about tomorrow, where it can bind a proton, it can bind directly CO2, and it can bind a molecule called bisphosphoglycerate or diphosphoglycerate. This favors the deoxy form. Upon oxygen binding, these all tend to be released, and that favors the oxygenated form. Okay? So these are effectors that favor deoxyhemoglobin. Oxygen is an effector that favors oxyhemoglobin. This is all part of the process. At the tissues, the CO2 and the proton favors deoxy, releasing oxygen for the tissues. At the lungs, the oxygen at the lungs at a higher partial pressure favors oxygen binding and release of CO2 so that it can be exhaled at the lungs. Okay. And so I've simply broken this up into this form. I'll show you this again tomorrow, where at the lungs, you're binding oxygen and releasing CO2. At the tissue, you're releasing oxygen and binding, making bicarb and binding CO2. And this is the overall net reaction that's going on in the plasma, the transport between the tissues and the lungs and the tissues. So that reaction that I was telling you about, the CO2 can non-enzymatically bind to the N-terminus. Now, hemoglobin has 4 chains, so this can happen at 4 different sites. And this non-enzymatic reaction is one of the ways that CO2 gets transported in your lungs. The N-terminus has a different pK. Okay, and so in a protein sequence, the N-terminus is a slightly lower pK, and that causes the proton to bind to the N-terminus. And so part of the protonation involves protonating the N-terminus of the 4 chains. Okay, so this is summarized here. There are 3 different ways that bicarb is transported. It's transported as bicarb. It's transported as soluble CO2. Remember, the CO2 normally is about 1.2 millimolar. And it's transported as carb-amino-hemoglobin. Okay, it's mostly bicarb, but these other forms contribute about 20%. These are the processes that can go on in hemoglobin. There's carb-amino-hemoglobin, all 4 chains, 2 alphas and 2 betas. BPG binding occurs primarily at the beta chains. There's actually only one site for PBG binding. And proton binding, it primarily occurs in a chain that's involved in converting the high affinity form to the low affinity form. I will be talking about in more detail tomorrow. Okay, sorry for that slight interruption. Okay, and then the other thing here has to do with buffering capacity. Okay, and so the buffering capacity has to do with the fact that hemoglobin is contributing to some of the buffering. There are other buffers that have to do with the phosphate buffer. Okay, and then the hemoglobin is also buffering through what we're going to talk about in terms of the Bohr effect. So there's histidines on the hemoglobin. There are other buffers like phosphate buffer. And then there's these specific sites that involve the Bohr effect that are also contributing to the effect. Now, this is a cartoon that a student last year drew out for themselves. I don't know why it's a devil. Okay, but they drew out a single BPG binding site. They drew out 4 oxygen binding sites. They drew out 4 CO2 binding sites, okay? So this is sort of a way that this person was using a cartoon to help them memorize the numbers of sites that are displayed here. All right, now let's rederive Henderson-Hasselbalch for the fact that CO2 is a gas, okay? And it's the same equation, but all we're really going to do is now take into effect the concentration units of the CO2. All right, so here's the overall equilibrium. CO2 is in equilibrium with bicarb and acid. Here's the equilibrium constant. Proton times bicarb divided by CO2. We rearrange this 1 over H on the left, 1 over K3. We take the logarithms. We end up with pH is equal to pK3 plus the log of the bicarb over the CO2. But the important thing here is that CO2 is a gas. So we can no longer use millimolar here. All right? So how do we convert millimolar to partial pressure? Okay, and so the answer is that the partial pressure with a fudge factor, which we'll call alpha here, is equal to the CO2 concentration. And numerically, alpha is 0.03 because 0.03 times 40 millimeters of mercury equals 1.2 millimolar. Okay, so this is telling you normal values of CO2 as partial pressure. It's normally 1.2 millimolar. It's normally 40 millimeters of mercury. And so in the Henderson-Hasselbalch equation, we now have to convert concentration to alpha times partial pressure, 0.03 times partial pressure. Okay? So when you solve this problem, you're going to use 24 divided by 0.03 times 40. It's still going to be 1.2. This ratio is still going to be 20. This is still going to be pH 7.4. You just need to know to use that 0.03 if I give you millimeters of mercury as part of the problem. Okay, so again, I can use, during the live lecture, we can turn this into a test. 24 millimeters of, millimolar of bicarb and 20 millimeters of mercury of CO2. Now, again, normal now is 40. So what we've done is we've dropped this by a half. So it's actually the same question. 6.1 plus the log, okay, of 24 over, but now you've got this 0.03 times 20. Okay? All right, so again, we've reduced this by a factor of 2. All right, and so this overall ratio is going down by a factor of 2, but that makes it a bigger negative number. The negative number is the log of 1 over 2. I think when I did that up above, I did that a little bit incorrectly. It's basically the log of a half. The log of a half is minus, am I doing this right? 24 over 20. So this ratio actually goes up by a factor of 2. So I'm actually doing this wrong. Look at that. It does go up by a factor of 2 because it goes, we're dividing by 2, so you're multiplying by 2. So it's the log of 2 is 0.3, 0.3 plus 7.4 is 7.7. Or you can plug all these numbers in and you'll get 7.7. Okay. Here's another one. If the bicarb is 12 millimolar and the CO2 is 20 millimeters of mercury, this is 12 over 0.03 times 20. This is still the log, but again, I want you to notice something. You can solve this by inspection. It goes from 24 down to 12. It goes from 40 down to 20. Both the numerator and the denominator compensate. This is still a ratio of 20. The log of 20 is still 1.3. When you add this to 6.1, you're still going to get 7.4. Okay, so both the bicarb and the CO2 both went down. So you're still going to get 7.4. Oh, let's go back here. Okay. So this is where we're now going to go. We're going to now start asking questions about how this regulation is occurring. Is the regulation occurring because we're adjusting the bicarb? Is the regulation occurring because we're adjusting the PCO2? Or is the regulation occurring because we're adjusting both? Henderson-Hasselbalch shows you that the pH is proportional to the logarithm of the bicarb over the CO2. Okay? The metabolic component, which is the CO2, is controlled by the kidney. The respiratory component is the PCO2, which is controlled by the lungs. Okay? So, which is it? Are the lungs acting? Are the kidney acting? Are they both acting? Okay. And then here is where we're going to now start thinking about this in an explicit way. If the bicarb goes down, then there's some kind of a decrease in the base, so that makes it acidosis, but the bicarb is from the kidney, so that's metabolic. If the CO2 goes up, that's increasing the acid, that's acidosis, but that's controlled in the lungs, that's respiratory. So you can have acidosis that is metabolic, the bicarb goes down. You can have acidosis that is respiratory, the CO2 goes up. Both of these will contribute to acidosis. Both of these will lower both of these will increase, both of these will increase the amount of proton, but decrease the pH. Okay. Alternatively, the bicarb can go up, and that would be alkalosis. That's metabolic. The PCO2 can go down. That's alkalosis. That's respiratory. Okay. So you can increase the numerator, and this gets bigger, and therefore the pH goes up. You can decrease the CO2, and this gets bigger, and the pH goes up. And both of these are called alkalosis. And so that's what we're talking about here. We're really talking about maintaining the ratio. So if the numerator goes up, the ratio gets bigger. If the denominator goes down, the ratio gets bigger. A bigger ratio is alkalosis, the pH goes up. If the numerator goes down, the ratio goes down. That's a lower pH. If the PCO2 goes up, then the ratio goes down. That's a lower pH. That's basically the way you need to think about this. Is there more acidosis? Is it the bicarb or is it the CO2 that's contributing? Is it metabolic or is it respiratory? Okay, so I've spoken now for 52 minutes, and generally this is where I would take a break in the live session. So what I'm going to do is I'm going to take a break for me. I'm not going to do anything other than advance the slide. And I'm going to take my headset off and get something to drink, clear my throat, and I'm going to come back in a few minutes. Okay, so talk to you in a second. This is a pre-recording, and so in the live session, we're going to do something very similar.
Hey, hi.
So why do you think that's too many people?
Well, okay, so you think it's okay. Actually, if she had told me there'll be 6 of us coming, I would have said no at the beginning. So I just feel sort of that I'm being pushed into something I would have said no to. But if you think it's okay, I'll just...
Well, he says that Paul and his girlfriend are only coming for a few days, and Jeffrey and Jeannie may come down.
Yeah, I know. I think that's okay. That's what I wanted to hear. If you think it's fine, I'll just let
it go. You'll be okay. Now, if she ended up bringing a party of people with Paul.
That's what I'm saying. I have no idea what she's doing. And I think it's rather dishonest to have got me into this position at this point. But I'm going to go with it.
Did you honestly think it would just be the two of them?
I thought she might bring the grandmother. That's what you and I discussed.
Right, but the implication also was, because Jeffrey was involved, that maybe Jeffrey would show up.
Yeah, maybe. But now we got a brother and his girlfriend, and
I think it will be okay. Now, would I let Paul go there by himself? No.
Of course not. I wouldn't have. But, so, whatever. If anything's done, we'll take care of whatever happens. That's okay. I'm just letting it be. I think it's wrong, but I'm going to let it be. All right? We'll be there, and we'll be the next people to be there. We'll take care of anything that happens there. That will be our job.
Angela's going to clean up everything.
Well, that's the problem, too. Andrea isn't that good at it. If I knew that, oh, yeah, Andrea can do it, I'm like, I have no idea. If it's anything out of Andrea's ordinary path, she's not going to take care of it, whatever it is. I have no idea what it is. I have no idea what can break. I have no idea. But you and I will take care of it. Okay, that's all I wanted to hear you say. All right, done.
Okay.
I will never do it again, though. This is my last Correia thing. Because unless it's Janet, no, I'm serious, unless it's Janet, that was just dishonest. I'm sorry, it was. And so, I'm not feeling good about it. I would never do that to somebody, for example. I would never do that to somebody. But I did it. I'm going with it. It's fine. All right. All right, that's all I wanted to hear. Everything okay?
Mm-hmm. Yeah.
Okay. All right. All right.
I'm in the middle of my talk, and right now I'm on the phone while I'm in my talk, but that's okay.
Oh, don't be mad at me, Bob.
I'm not mad at you. I took a break at 50 minutes, and I told him I was going to get a drink, which I am. And
Okay.
this isn't a live session. This is a recording.
Right, I know.
Okay, I'm back from my break. It was a little less than 10-minute break. So that's what we're going to do, something like that when I do this live on Wednesday. Okay, so what I was just doing was showing you the fact that there's this balance between acidosis and alkalosis. It's controlled by the log term, the ratio of the base over the acid. And the numerator can go up or down. The denominator can go up or down. It depends on if it's a metabolic or a respiratory change. Okay? So the change in the CO2 concentration, which is respiratory, it's controlled by breathing in and out, can be either acidosis or alkalosis. The CO2 goes up, that's acidosis. If the CO2 goes down, that's alkalosis. Okay? So when you're looking at a change in a patient's profile, in a patient's arterial blood gases, has the CO2 changed? And does it correspond to the change in pH, yes or no? If the CO2 goes up and it's acidosis, then it's a respiratory acidosis. If the CO2 goes down and it's alkalosis, then it's a respiratory alkalosis. Alternatively, the numerator, the bicarb, can go up or down. This is the metabolic component. If the bicarb goes up, that's alkalosis. You've raised the concentration of the base. If the bicarb goes down, that's acidosis. You've lowered the concentration of the base. Okay? So you can have respiratory or metabolic, acidosis or alkalosis. You identify which one it is by the primary change. The CO2 change corresponding to the pH, did the bicarb change corresponding to the pH? Okay. So this says the same thing here in terms of the equilibrium that's going on, but appreciate this equilibrium is Henderson-Hasselbalch. This equilibrium is transport of CO2 from the tissues to the lungs. This equilibrium is excretion or reabsorption of bicarb at the kidneys. It's a much bigger process that's going on than just this equilibrium. The Henderson-Hasselbalch, the pH, basically reflects all of these other changes. Okay? So this says, again, basically what I just said. If the CO2 goes up, you're raising the acid, it's more acidic, there's more proton, but that means lower pH. Okay? Below 7.4 is acidosis. If the CO2 goes down, that's more alkaline, that's less proton, less acid, that's higher pH. And likewise, the bicarb. If the bicarb goes down, that's more acidic, the less base, more acidic, and increase in protons. If the bicarb goes up, that's more base, it's more alkaline, it's a decrease in protons, that's higher pH. Okay. Now, almost nothing occurs. There are some things, but basically nothing occurs independent of one another. If you have a metabolic disorder, this may and probably will show up in your respiratory behavior. If you have a respiratory problem, you will have a compensation or a change in your kidneys to kind of offset what's going on in your respiratory system. Okay, and so the mixed disorder simply means the primary disorder often is compensated by a secondary or a compensation. So, for example, if you have metabolic acidosis, what that means is there's something in your blood that causes acidosis, okay? So ketoacidosis would be something that you have when you have a problem with insulin, for example, a diabetic ketoacidosis, okay? So these ketone bodies are basically weak carboxylic acids that dissociate their protons. They titrate the bicarb down, okay? And so the bicarb going down lowers the pH. It's more acidic. In response to this, your brainstem knows to tell you to hyperventilate. So you start breathing faster to eliminate more of the acid that's being produced. So the keto acid titrates the bicarb over to the CO2, and then the breathing gets rid of the CO2, and that increased rate of breathing, hyperventilation, helps to get rid of this volatile acid that's being produced by the ketone acids. So metabolic acidosis is usually associated with low bicarb, increased breathing rate. The compensation is increased breathing rate, okay? Now, the way that we know that this is not respiratory acidosis is the CO2 is going down a little bit. Remember in the example up above, it went from 1.2 to 1.1. Okay? It's going down a little bit. That does not account for acidosis. That accounts for a compensation to correct the ratio. If the bicarb goes down, by making the CO2 go down, that tries to keep the ratio closer to constant. It can't keep up indefinitely, but it tries to, okay? Now, respiratory acidosis. This is emphysema or chronic lung disease or chronic obstructive pulmonary disease, okay? This is a situation where you can't get rid of the CO2 because you have problems transporting gas across the membranes of the lungs, okay? This also causes a problem getting oxygen into your system, right? And so what this means is you have an increase in the amount of CO2 because you can't breathe in enough, you can't exhale the CO2 efficiently. So you're walking around with elevated amounts of CO2. You have acidosis. Over time, what happens is the bicarb concentration goes up, okay? And so the bicarb concentration increases to help restore the pH to normal, to help to compensate for the change in the CO2. So you have increased CO2, you will end up with increased bicarb caused by the kidneys reabsorbing more and more bicarb. Okay, so people in chronic obstructive pulmonary disease tend to walk around with elevated CO2 and elevated bicarb. The CO2 is what's causing the acidosis. CO2 concentration is high. The bicarb concentration is also high. High bicarb doesn't cause acidosis. It compensates for the acidosis by trying to keep the ratio closer to normal. All right. Now, in addition to all of this, there's an electrolyte imbalance that occurs in these processes. Recall, sodium, potassium, bicarb, chloride, both in the plasma and in the interstitial fluids. So the sodium and potassium is almost completely offset by the charge on the bicarb and the chloride. If the bicarb concentration changes, that will show up in this ratio, or that will show up in this balance. Okay, and that's shown here. Normally, when we do a blood gas and we make measurements on our blood, we add up the total sodium and potassium, and we compare it to the chloride and the bicarb. Now, normal sodium is around 140 millimolar, and normal chloride is around 100, 105, 106 millimolar. Normal potassium is around 3.5 to 5 millimolar. So if you just do the math here, you can see 140 plus 5 is 145. 105 plus 24, okay, is something like 129. All right. And so the difference between those two sums is somewhere around 15, 16. So if you look at these ranges and plug in various numbers, you'll see that this normal anion gap is around 12 to 16 millimolar. Now, lots of people like to make this calculation without the potassium. Okay, since it's the small number, they should say ignore it, and then the difference will be around 8 to 12. Okay, so this is a biochemistry class. We're not going to ignore the potassium. Okay, and so normally when I ask you to calculate or tell me what the anion gap is, I want to know what the sodium plus potassium minus the chloride plus bicarb is. Now, in something like metabolic acidosis, what I just told you is the bicarb gets titrated down. But over time, people in metabolic acidosis begin losing volume. Okay, they begin having problems with water retention. They begin having problems with what's going on in their kidney. So they begin excreting a lot of volume, and that excretion begins to get rid of various electrolytes. Okay, so you may start seeing changes in sodium and chloride in addition to changes in the bicarb. And that becomes one of the diagnoses that we end up talking about. Okay, so this is not a very legible slide to me, even in my format here, but this is taken out of a biochemistry book that is Medical Biochemistry, and it lists normal values in blood, okay? Normal clinical values in urine and normal clinical values in blood. Now, we're talking about there's bicarb, there's chloride, there's normal pH, there's potassium, there's sodium, etc. There's normal oxygen, I think is what that is. Okay, there's normal bicarb up at the top. So there are normal values here and lots of other things that might be involved that we'll talk about in other contexts, okay? You can see albumin here is 3.1 to 4.3. So that's 31 to 43 milligrams per milliliter. Okay. So lots of these normal values are here, and in some clinical exams, they often provide you with a table of normal values. All right. So here's what we're talking about now at another level of control that we have to take into account. We've been talking about a relationship between what's going on at the lungs and what's going on at the tissues. All right. And so we have CO2 going out, oxygen coming in. We have the CO2 coming from the tissues. We have the oxygen going to the tissues, okay? And we have systems that sense normal levels of oxygen and normal levels of CO2, okay? If you have low oxygen levels, there's a receptor in the heart, a baroreceptor in the aortic arch of the heart that senses this and causes your heart to beat faster, okay? Want to pump more blood, get more oxygen to the tissues. If we have elevated CO2, there's a sensor in the brainstem that senses elevated CO2, and it causes you to breathe faster, causes you to get rid of that high CO2. So it's not just this magic, okay, that we're getting rid of CO2, we're taking in oxygen, the tissues is doing this exchange, CO2 out, oxygen in. But there are other regulatory processes in the breathing and in the heart rate that help to regulate this overall balance. All right. Now, what other kinds of processes might be messed up, and what can we say about that? Okay. And one of the ways that we talk about this is with and without an anion gap. This helps in the diagnosis because if there is an anion gap, that tells you something about the kind of process that must be going on, as opposed to processes that do not involve anion gaps. It tells you that there's some imbalance in electrolytes, some imbalance in bicarb levels that helps you do the diagnosis. So you can see metabolic acidosis with a wide anion gap is the term that's used. Things like ketosis. This is primarily diabetes. It can apply to starvation. It can apply to alcohol intoxication. Mostly the examples you're going to see are diabetic ketoacidosis. There can be a lactic acidosis. Lactic acidosis can come, for example, from some kind of overactive muscle activity. Okay, there can be some other metabolic imbalance that could be going on. But generally speaking, these will produce acids that go into the bloodstream and titrate down the bicarb, causing an anion gap. Okay, there can be defects in metabolism that I'm not going to talk about. But the other things that I primarily talk about are ingestions of poisons. So, for example, salicylate overdose, that's aspirin overdose. If you ingest too much aspirin, remember it goes into your bloodstream, it dissociates protons, that causes a titration of the bicarb that causes an anion gap, causes a bicarb being titrated. Methanol ingestion. It's not clear why people drink methanol. They don't know that they shouldn't drink methanol if they're around it. They think it's just like alcohol. It will get you drunk, but it will also cause metabolic poison. I'm going to tell you about that in a second. But the breakdown of methanol involves the formation of an acid, and that acid actually will cause an anion gap. Ethylene glycol poisoning. If you drink ethylene glycol, again, why somebody would do that is not clear, but it happens all the time. It's broken down, and these are broken down in a similar manner to alcohol being broken down. And there are diagnostic ways that you can tell that somebody has ingested ethylene glycol, okay? And it causes an anion gap. Notice that methanol and ethylene glycol, before they're broken down, are also uncharged. And so they actually contribute to the osmolar gap. So that's another way that you can diagnose those. Now, we're not going to talk about too many of these other things. Normal anion gap is associated with diarrhea. Normal anion gap can be associated with vomiting. Okay, and so depending on the kinds of problems that you have, you may have a normal anion gap, but there are other things that might be going down that can cause acidosis or alkalosis that we can talk about. Now, this list of things is summarized with a mnemonic device. Medical students like these mnemonic devices. Clinicians tend not to use these mnemonic devices because once they've been practicing medicine for a long time, they don't use mnemonic devices. They actually just know stuff. Okay, someday that will be true for you too. All right. And so the mnemonic device is mud piles. Methanol, uremia, that's kidney failure. DKA, diabetic ketoacidosis. Paraaldehyde, which you almost never see. Some kind of an iron imbalance. Lactic acidosis. Ethanol ingestion. Salicylates. Okay. So primarily, you and I are going to talk about methanol, uremia, DKA, ethanol, salicylate. Okay, some kind of poison. All right. Okay, so here are the examples of ethylene glycol poisoning and methanol poisoning. Okay, and you can see in this this paper is something that I usually put out there for you to read, and so I need to now go check to make sure this is out there in the reading list for this lecture Wednesday afternoon. Okay, so these cartoons are showing you what's going on. All right, so methanol poisoning occurs from the ingestion of windshield washer fluid, or sometimes straight methanol. People might put it into drinks. All right. The problem is that it gets broken down in exactly the same way that ethanol gets broken down. Alcohol dehydrogenase breaks it down into formaldehyde, and that formaldehyde then gets broken down into formic acid. So there's the acid. So there are two things that happen here. The formaldehyde actually is a reducing agent. It'll cross-link your liver. So it will cause tissue damage. All right? This is how you fix cadavers, basically, right? And then the alcohol dehydrogenase will convert it to formic acid. Formic acid will cause metabolic acidosis, but formic acid will also accumulate in the eye, and in the eye it will cause blindness. Okay, so methanol poisoning will cause damage to the liver, metabolic acidosis, and damage to the eyes. Okay. Ethylene glycol poisoning It will be broken down just like ethanol, just like methanol. It will be broken down into glutaraldehyde and glycolic acid. Again, it will cause metabolic acidosis. But then this glycolic acid will be metabolized into something called oxalic acid. Oxalic acid in combination with calcium is insoluble, and it will accumulate as this white substance in your kidney. Okay? And so if you can see a whitish substance or white particles in your urine and in the kidney, then that's partial evidence for ethylene glycol absorption. You'll get metabolic acidosis. All right? The glutaraldehyde will cause some liver damage. The oxalic acid will accumulate as calcium oxalate crystals in the liver, in the kidney. And so that will help you diagnose this. All right? Now, there are drugs that are available for treatment. And notice the drugs in part are involved in inhibition of alcohol dehydrogenase. They're also involved in, and then you can also do hemodialysis. So you can also attempt to kind of clean up the blood, okay, by doing it that way. And that's basically it. Now, the ethanol here is interesting because you notice it's in both places. You can give an IV that contains ethanol to somebody who has ingested ethylene glycol and methanol. What you're basically doing is you're doing competitive inhibition. What you're basically doing is you're drinking alcohol to compete with the alcohol dehydrogenase so that the ethylene glycol or the methanol isn't degraded and made into a toxic substance. Okay? This is probably not the preferred way of doing it. The preferred way of doing it is to inhibit the enzyme. The preferred way of doing it is to actually do some kind of dialysis to get rid of the contaminants. I don't really know the time frame of this, how quickly you need to act before there's severe damage. Okay. There's an old episode of House, if you're familiar with that TV show, where he sits down with a patient with a bottle of whiskey and he starts drinking shots with this guy. And basically, he's using ethanol as an inhibitor. Okay, so that's what he's doing. That's probably something that'll get you fired, not on television, but certainly in practice. Okay. So this is a problem that I have asked or we've seen before in exams. It involves a patient who has had nausea and vomiting. She has gastroenteritis, lightheadedness, can't really ingest food or water, so she can't maintain water intake. She has nausea and vomiting, okay? Her arterial bloods are most likely to show which of the following. So what this is asking you to do is imagine what the numbers might be, okay? So the first value is pH. The second value is the PCO2, okay? And the third value is the bicarb. So notice, there are lots of options here. Is the PCO2 down or up? Is the bicarb down or up? Is the pH acidotic or alkalotic? We're giving you multiple choices here. What's really going on here is this person has nausea and vomiting. They're getting rid of acid by vomiting. They're getting rid of acid for their stomach. So this person is probably going to be alkalotic. But is their bicarb up or down? Is their PCO2 up or down? Okay, so that becomes the question here. What's happening? They're vomiting and they're not taking in water. So they probably have loss of volume. And so what does that lead to here? Now, I'm asking this question to you because I want you to be aware of the fact that this gets really complicated. Much more complicated than the simple way that I've been teaching it to you. Okay, and so here's what Dr. Bagat says about this question. 3 days of vomiting, lightheadedness, only small amounts of intake of fluid is hypovolemic. So you have reduced volume in your bloodstream. Vomiting leads to loss of acid. So patients have metabolic alkalosis, which is also incompletely compensated by respiratory acidosis. So respiratory acidosis means that you're retaining CO2. So that means in this question up above, the CO2 level must be higher. So E might be the right answer here, okay? Because hypoxemia prevents suppression of the respiratory drive. So the most suitable answer is E, and then he goes into other possibilities that, depending on the stem, might compensate and make this more complicated. So, for example, the stem doesn't say diarrhea. That would introduce a whole other level of loss of bicarb through the diarrhea. Okay? So things can get more complicated, and Dr. Bagat will talk to you about problems like this. Okay. So I did that as a final section on the overall overview, okay? And so now what we want to do is we want to talk about the kidney. And we're going to do this in a much more abbreviated manner, and we're going to talk about metabolic problems in the kidney. Okay. So the kidney has a number of different functions. We think of it as being involved in excretion and regulation, okay? So it removes water-soluble waste products. It maintains maintenance of water levels, electrolyte levels, and acid-base balance. Okay, so it's reabsorbing water, it's reabsorbing or losing bicarb, it's reabsorbing or losing sodium, potassium, and it's excreting things like protonated phosphate or protonated urea, protonated ammonia, and getting rid of acid through the kidney. It's also involved in getting rid of waste products, urea, creatinine, uric acid. These are metabolic byproducts, and it gets rid of them. If you don't get rid of them, then the urea will cause uremia, azotemia of high elevated BUN, blood urea nitrogen. It's also involved in gluconeogenesis. You'll talk about that in other parts of the course. It's also involved in various endocrine functions. Okay, so renin and erythropoietin are produced in the kidney. It's involved in synthesis of vitamin D, and it's involved in the breakdown of certain hormones, specifically insulin and PTH. Okay. So the way that this integrates into metabolism, and this is just a prelude to what you're going to see in other parts of the course. Muscle metabolism produces breakdown products of amino acids, and one of those is glutamine. Glutamine is broken down into ammonia. Ammonia is then used to synthesize urea. And that ammonia, glutamate, and urea are all excreted through the kidney. So notice the urea is a waste product. Urea is a denaturant, by the way. It will actually, at high concentrations, denature proteins. It never quite get that high in our body. But somebody in kidney failure will actually accumulate a lot of urea. Okay, you can actually smell urea. It has a smell, so you can actually tell that somebody is in uremia. And then it will get rid of ammonia. Notice it's a protonated form. And so that's one way of getting rid of the acid. Okay. Creatine was on that list. Arginine and glycine are broken down through this pathway and eventually into creatine. And then creatine is phosphorylated in tissues to make creatine phosphate. This creatine phosphate is an energy source for metabolism. It rephosphorylates ADP. Okay, so it's used as a backup energy source in muscle. Non-enzymatically, creatine can be made into creatinine. And so there's a certain level of creatinine in our bloodstream. It's this non-enzymatic breakdown of creatine, and our kidneys get rid of this creatinine. The concentration of creatinine is usually measured as a fraction of muscle mass. So you have more of this depending upon how much muscle you have, how big you are and how much muscle you have. So this is summarized in a slightly different way. Creatine, through the action of creatine phosphate, is phosphorylated. It can be used to phosphorylate ADP into ATP. Notice the delta G from a table I showed you in L4 has a minus 10.3 kcals per mole for delta G naught. So it has a driving force for rephosphorylating ATP. Once some small fraction of this is broken down into creatinine, and your kidney is used to get rid of that. Okay. Our bodies produce acid. Okay. Metabolism and degradation produces acids. Okay. So carbonic acid is the one that we've been primarily talking about. That's the volatile CO2 that is gotten rid of by our lungs. Sulfuric acid, hydrochloric acid, phosphoric acid, lactic, citric, ammonia, uric, ketone bodies are all non-volatile. They're soluble in water, and we have to get rid of all of this stuff through our kidneys. Okay? And so our kidneys are involved in breaking down all of these acids. The ketone bodies are the things that we associate with diabetes. They refer to acetoacetic acid and beta-hydroxybutyrate. You've talked about this already a little bit with Dr. Brown. You'll talk about this a lot with other people. These are essentially breakdown products from lipid metabolism. And if there's an imbalance in lipid metabolism, for example, we don't have insulin to regulate lipid metabolism. And so we're starting to break down lipids, even though we're hungry and we don't have enough food in our bodies. It will produce elevated ketone bodies, elevated acetoacetic acid, and beta-hydroxybutyrate. And these are the things that will cause metabolic acidosis. Where do these things come from? Well, sulfuric acid comes from the breakdown of sulfur-containing amino acids, things like methionine. Hydrochloric acid comes from breaking down cationic amino acids. Phosphoric acid comes from the degradation of nucleic acids. Uric acid comes from the breakdown of PRPP and AMP, GMP. Okay, so this is the urate that the kidney gets rid of. Incomplete oxidative phosphorylation is what produces lactic acid. You're going to talk about that a lot. But if you don't have enough oxygen and if you don't have enough oxidative phosphorylation going on, you will make a byproduct off of gluconeogenesis. You'll make a lot of lactic acid. Citric acid cycle, the breakdown product of citric acid. Glutamine is broken down into ammonia. I just showed you that. Incomplete oxidation of fatty acids will produce ketone bodies. So this is sort of a summary of all of metabolism and where all of these non-volatile acids come from. This is what the kidney is actually doing. Okay? So we get rid of a lot of volatile acid every single day just by breathing. But we also need to get rid of a lot of non-volatile acids. Okay, and this is what the kidney is doing. Don't worry about all these numbers right now. This is in the reading of another section. Now, in addition to all of this, you and I ingest acids. So depending on what your eating habits are, we tend to eat lots of proteins and nucleic acids. Okay, and so they break down in the ways that I've just showed you to make acidic breakdown products. We might sweeten our food with things that contribute through acetic acid in barbecue sauce or sweet and sour. We might take an excess of drugs like aspirin. We might ingest ethanol, okay? All of which gets broken down into acids. We might inadvertently ingest methanol or ethylene glycol or brush our teeth with some weird Chinese toothpaste, all of which is going to contribute to acid in our bloodstream. Okay. Generally, the urine that we excrete is either very acidic or slightly alkaline. All right. Now, at the lowest pH, 4.4, appreciate this is only 40 micromolar. This is only 0.04 millimolar. Okay. If we have to excrete 50 milliequivalents of something per day, this is not a very efficient way of doing it. We don't excrete pH acid directly. We actually have to excrete it bound to something that is at much higher concentrations than this. All right. So instead of excreting protons, we excrete protonated phosphate, or we excrete ammonia. These allow us to excrete far more protons, far more acid. Okay. Some of the bicarb that we excrete can be reabsorbed. Okay. The total acidity in our urine is a question of how much total ammonia and how much other stuff that we lose. So I'm showing you phosphoric acid here, monobasic phosphate being excreted, but there are other protonatable groups that can be excreted as well in our blood, in our urine. The total excretion of acid is achieved by a carrier, something that can carry protons rather than directly by the pH of the urine. Okay. I'm not going to get in the actual function of the kidney. This is the structure of the kidney. You're going to talk about this in physiology, I guess, in the spring. I don't think you're going to get to that before Christmas. It excretes lots of water or reabsorbs water, lots of solutes, lots of acids, etc. It concentrates it all down, reabsorbing most of the water, reabsorbing some of the bicarb to be able to do that. Now, the excretion process looks not unlike what we observed in the erythrocytes. Okay? If you have bicarb, the bicarb can react to make CO2 and water, and the CO2 can be reabsorbed. All right? That reabsorbed CO2 can make carbonic acid that then is broken down immediately into bicarb and protons, and that's what you reabsorb. And so there's an enzymatic cycle here of taking the bicarb, pulling it back into the renal tubular cells and reabsorbing it into the blood. Okay, so this reabsorption of bicarb is something that's regulated in the kidneys. The excretion, as I've just said to you, occurs by protonated ammonia or protonated phosphate, and this is what usually goes into our urine. This is the usual carrier of the protons that we're getting rid of, the non-volatile acid that we're getting rid of. It usually gets excreted as ammonia and monobasic phosphate. Okay, here, ammonia and monobasic phosphate. Okay. The source of that ammonia is breakdown of amino acids. Phosphate is just floating around in our bloodstream. Okay. So to re-summarize, the kidney is involved in excretion of waste products. I told you about urea, amino acids, creatinine, non-enzymatic breakdown of creatine, urate, which is from the DNA, nucleic acids, maintenance of water, electrolyte, acid-base balance, and these other processes that we're not talking about. Now, I want to mention one other thing because I don't seem to have a slide for this here. Okay. When you excrete ammonia and phosphate in this manner, that's charged. And so you must actually have a counterion to go along with it during this excretion process. So there has to be a negatively charged electrolyte, chloride, and a positively charged electrolyte, sodium or potassium, along with these charged proton carriers. Okay? So at the same time that you're doing this, you're also excreting chloride ion, and you're also excreting sodium and or potassium. Okay? And so depending on what's going on in your body, you also are potentially in danger of losing electrolytes through the excretion of these proton carriers. And so this is something else that you have to be watching for when you do this. Okay. So when I redo this live, I may look at this in a little more detail to give this to you. Okay. So it looks like I'm a little bit ahead of schedule here. So that's all I have to say for today in this topic. The live session will go hopefully in a similar way. So it's Wednesday afternoon and quiz number 1 has just popped up. So what that means is there's a quiz in Canvas that you now should take. You should go looking for where the quiz is. It covers material on the first 6 lectures, Dr. Brown's lectures, my first 4 lectures, and this clinical correlation. These are practice questions to get you used to the kinds of questions that we're going to give you in the exam next Tuesday. So go look at this quiz. Another quiz will pop up on Friday, and that will correspond to the lectures that we're going to give tomorrow and Friday. Okay, so 7 through 11. On Friday afternoon, I'll do a review. So it'll cover all of the topics through the first 11 lectures that I've given you. And so that's all I have to say for today. Okay, so I think I'm going to come up here and I'm going to stop. So I'm going to end our lecture, and this will get posted separately someplace on the web. I'm actually putting these on YouTube, so you'll be able to find these on YouTube. I'll direct you to them. But the live broadcast will also be appearing